Looks can be deceptive, are they? This is a relatively simpler case. 64-year-old male who presented with him to hematology department with complaints of easy fatigability and weakness. There was no history of significant weight loss, night sweats, or fever. And physical examination was notable for the presence of a single right axillary lymph node. We initially received the CBC of this patient. So there was mild leukocytosis, the count is 22,000, and with relative lymphocytosis. So thinking it to be a simple case of probably CLL, the resident just subjected the sample to flow cytometry, saying that probably it's a CLL with some CLL PL like cells or some mild atypia. So again, a higher power image of the same, largely small mature appearing lymphoid cells and some showing mild atypia. So the flow cytometry, to our surprise, showed basically a majority of these cells to be CD3 positive. And when we look at the CD4 and 8 ratio, we had more than 90% CD4 positive cells, a small trail of cells which is co-expressing CD4 and 8. And then there's a relative paucity of CD8 positive cells. So that led us to think that are we probably dealing with a TLPD rather than a typical CLL. The cells were largely alpha beta, and there was, however, no loss of 3 or 5 or 2, though the expression of CD7 was slightly heterogeneous, I would say. So we were not able to actually conclude based on flow cytometry whether we are actually dealing with a clonal population of T cells or is it reactive. And simultaneously, we also received the lymph node of the patient, whereas the lymph node, if we can say, I'm sorry, seems to be out of focus, but here again, this is the architecture is effaced, and on higher power, we can see that we have a admixture of larger cells with prominent nucleolus and smaller mature appearing lymphoid cells, but they are not looking like typical small mature lymphoid cells. They looked atypical when we had a look at it. So immunohistochemically, the larger cells were positive for CD20. The background cells were largely positive for CD4. Then CD2 was positive in these T cells. CD57 sparsely positive, CD10 was negative, and these CD20 positive cells were negative for CD15 and 30. So summarizing what was there, CD20, PAX5, BOB1 and EMA was positive focally, while CD15 and CD30 were negative. The background cells were largely T cells. There was no nodular pattern appreciated, and the CD4 was much more than CD8, even on immunohistochemistry, and so was the finding in the peripheral blood. So with that, we were left with this challenge, whether we are dealing with a T cell rich B cell lymphoma, or is it an NLPHD pattern E, but there were hardly any nodules. Or are we dealing with a PTCL NOS because the peripheral blood is showing CD4 positive T cells with almost 50 to 60% ratio of CD4 is to CD8. And so to confuse the audience further, these are 3 different pictures of these 3 entities, and where all, you can have a admixture of these. One of them is NLPHD, one of them is actually T cell rich B cell lymphoma, and one of them is PTCL with RS-like cells. So morphologically, sorting this out seems to be challenging, though there are certain clues which help us to differentiate between PTCL, NOS, or rather, I would say there are clues which help us to differentiate between NLPHD and T cell rich B cell lymphoma. So with the presence of those large number of T cells in the peripheral blood and a morphology of NLPHD like morphology in the lymph node, we were not very sure which population seems to be clonal. So these are just some of the studies where PTCL cases have been shown to have RS-like cells. This can be PTCL TFH or even PTCL NOS, and even angioimmunoblastic T cell lymphomas have shown to have RS-like cells. And interestingly, in majority of these, what I wanted to highlight that these RS-like cells will actually show a immunophenotype also like RS. So they'll be positive for 15 and 30. And either the TFH phenotype or the PTCL NOS. So here PTCL TFH phenotype seemed a very close differential because we had these RS-like cells, and then the background cells were largely CD4 positive, though they were negative for CD10 and other follicular helper T cell markers. So I'll skip this part, and I would like to thank Dr. Neeraj for coming to our rescue. The sample was sent across to Dr. Neeraj, and clearly what it brought out was that the TCR is showing this Gaussian curve pattern, whereas in the when we did the B cell rearrangement studies, that has brought out the presence of a clonal B cell population. So basically what we sent both the peripheral blood as well as the lymph node sample for these rearrangement studies, and has beautifully brought out that the T cells are possibly polyclonal, and we are actually dealing with a B cell lymphoma. So a final diagnosis of NLPHL with pattern E was reported. So the discussion is largely focused on this, that NL-PhD can have a lot of morphological mimickers, though IHC is helpful in quite a significant number of cases, but there are certain rare cases like these which can present as a diagnostic challenge. And these are just subtle pointers where even before we had sent the sample out for genetic testing, we had kind of mentally thought that we are probably dealing with the NL-PHL, because though there were no nodules, but the pattern was probably a pattern E, the 4 positive T cells and some rosetting was appreciated. And the background cells in T cell rich B cell lymphoma are usually 8 positive cells. What was odd was a significant number of lymphocytes in the peripheral blood, which is not normally reported with NL-PhD. So molecular profiling came to our rescue and it helped us to differentiate between a T cell lymphoma versus a B cell lymphoma. This is the department. Thank you.